Hi, everybody. Welcome to Powerful Parkinson's, Powerful People. Nice to have everyone on with us today. I'm really excited to have our special guest, Dr. Michael Soileau here, movement disorder specialist practicing in Georgetown, Texas, right outside of Austin, about 20 or 30 minutes away. And
Thanks for having me.
yeah, sure. It's great to have you and great to see you. I know our paths have crossed a
Yeah,
few times
so good to
over
see you
the
again.
years. Yeah, yeah. And, I think just so everybody knows that you not only see patients, you train residents, you work with
Yeah,
students, right? And
that's
most
right.
recently, you have been elected as the president of the Texas Neurological Society. So
Yes,
congratulations
thank you.
on that.
Thank
Yeah,
you. Yeah,
yeah.
it's a lot of fun. Lots of hats to wear, so to speak, but it's really good.
Good, good. That's amazing. Well, so I guess today we're going to be talking about some of the newer developments in Parkinson's, but I thought
Yeah,
we could just start out by you filling in the audience about what a movement disorder specialist
sure.
is.
Yeah.
Okay.
So it's one of the most common questions that we get really is why should we see a movement disorder specialist over maybe a general neurologist, and why do the movement disorder specialists have such long waits? And what does that even mean? And is it worth it? And should I go? So we get that question quite a bit. So a movement disorder specialist is someone who has had 4 years of medical school, 4 years of neurology residency, and then usually 1 to 2 years of extra training specifically in movement disorders. And that could include medical and surgical management of movement disorders. It could include research, all kinds of things. And so how it's different from a general neurologist is a lot of times general neurologists will be specialists in maybe muscle or nerves, but they do a little bit of everything. So just like a primary care doctor does a little bit of everything, a general neurologist has to know, really, they're a specialist in everything. And that's a daunting task these days with how much everything is just skyrocketed and exploded in terms of treatment for things like multiple sclerosis and neuromuscular conditions and all these things. And so they have to know a whole lot. So whereas really in our practice of movement disorders, the only thing that we focus on is movement disorders. And so not to say that that's not a lot either, because this is a really happening time right now in Parkinson's. Lots of new therapies, lots of clinical research, lots of new developments, diagnostic tools, all kinds of things. So it's a lot to keep up with just in and of itself. And so the other thing I'll add is that movement disorder specialists tend to work in a very multidisciplinary fashion. So it's not uncommon for us to have advanced practice practitioners like PAs or NPs. We work very closely with physical therapists, occupational therapists, speech pathologists, social workers, home health agency, you name it. It's a village, so to speak, to treat these patients with Parkinson's and other movement disorders. And so, so we have a very close working relationship really around the state, because that's our catchment area. So we have a working relationship with all these folks, because that's really the comprehensive way to take care of patients with Parkinson's is multidisciplinary fashion.
Yeah, I absolutely. I mean, it just affects every aspect of the person
Yeah,
and
sure
the
does.
family. So it's so
Yep.
important that you have that multidisciplinary approach. And but I know it's really hard to find a movement disorder specialist when you need them. I mean, and in certain
Yes.
areas they don't even exist.
Right. Yeah. Some states hardly have one or two in the entire state, and we're blessed, at least in our region here, we have 6 or 7 movement disorder specialists, and of course everyone is busy and everyone works hard to see patients of this. With COVID, one blessing that came out of that was the ability to do telemedicine visits and virtual visits.
Yeah.
And remember that a lot of what we do as movement disorder specialists, we're able to see and observe things in public. This is why I get slapped by my wife and says, "Stop staring," because movement disorders are everywhere. But truly, we can watch a patient talk and how they move, how they touch their face, and how they do everything. and tell a lot about them. So when we have patients from El Paso or the Valley or elsewhere, the virtual visits have really helped bridge the gap to the access shortage.
Yeah,
So that's been a huge thing.
Can someone start to see you as a virtual, or do they? Yeah. Okay.
Yeah, they can. The only thing that we have to be mindful of is if you're licensed, if a physician is licensed in the state of Texas, really the patient needs to have a Texas address.
Yeah.
Or else if they live in another state, you have to have a medical license in that state. So that's the only thing to be mindful of, but we certainly have the ability to see patients remotely, even as a new patient.
Yeah.
I think most of our population really enjoys seeing us in person, and we certainly prefer that and love that, but we understand that things come up, and if freezes happen, as do in Texas sometimes, or crazy weather things, or whatever the case may be, it just makes a really good option to be able to see patients that way.
Yeah,
so
that is fantastic.
Yeah.
So I guess maybe we can I was going to ask you, before we get into the new developments, because I saw on your website, you talked about how you like to teach people about the art of treating PD.
Yeah.
And I'm extremely been involved in Parkinson's for quite a while now, so I fully believe that, but I'd like to know your take on that.
Yeah, so I think when we're treating Parkinson's and really any movement disorder, but especially Parkinson's, we have to really keep an open mind. And as you've probably heard, what you read in textbooks are not always how it is in the real world. And our patients will tell us what they feel, and we have to kind of interpret that and figure out, is this Parkinson's? Is this neuromuscular? Is this another issue? What's going on? And I think with experience comes deciphering that and kind of demystifying what that means. So for example, if a patient says, if they call us and say I'm moving too much, well, that's hard to interpret at face value, because in some reasons they may be wiggling and be dyskinetic, which means they have too much medicine, and that means one thing for treatment. On the same token, they may say I'm moving too much and it be tremor, and that means we need to increase medicine, not reduce medicine. So we really have to kind of figure that out. Or if they may say, I feel pain, or I feel panicky, or I feel this or that, and we have to kind of figure out if it's or something else. So to me, that is especially an art. And I think the fun thing is you can go to 5 different movement disorder specialists. Everyone's trying to achieve the same thing. But again, how you get from point A to point B is so different depending on who you go to. And that's the beauty. That's what kind of makes it individualized. And so I love that. And not to mention, we understand too that it takes time to treat Parkinson's appropriately. So it's hard to treat Parkinson's in 10 minutes. And unfortunately, our healthcare system is built that sometimes that is the case, and we don't like that very much, but we try to make our appointments a little longer, but it takes time. And so when our patients are explaining something to us, we have to really kind of sort that out with them. Sometimes their caregivers too have things they want to say and they need to say, and we're not just taking care of a patient, you're taking care of them as well, their care partner. And so a lot of times if they have an empty tank of gas because they're a caregiver, that's its own visit sometimes, just to kind of address some of those things. And that's important in any movement disorder really, but especially in Parkinson's. And so that's all part of the art of treating this. And this is what we love, is we get to know our patients really well, as you could imagine. So.
Yeah, well, that's what, when we're working with people with Parkinson's so frequently, need to speak up. But when we work with people with Parkinson's, they're like, well, so-and-so is taking this medication, but it doesn't work for me.
Right.
And I know every person is different. I mean,
Yes.
we always say, well, if you know one person with
That's
Parkinson's,
right.
you know one
Very
person with
much.
Parkinson's. So, so that, I know it's very complex,
Yeah.
and I appreciate that vision because I think it's really important, that
Yep.
tailoring for each person.
Hmm.
Well, can we just maybe let's go ahead and jump right into,
Sure.
like, I know there was a new drug that was just released by the FDA. Do you want to
Yeah,
talk about
yeah,
that?
happy to chat about that.
Yeah,
So it's a
yes.
really exciting time just in Parkinson's in general, as I said. Not that we want anyone to have any kind of illness, especially Parkinson's, but I can literally remember a day when we didn't have as many options as we do now, and it's just nice to be able to think strategically about what therapies to provide. And so there are actually two recently approved FDA. The FDA has recently approved two new products that we've been waiting for quite some time. The first is an infusion that is delivered underneath the skin. So Levodopa, I think we're up to 9 versions of Levodopa now, or something like that, which most patients don't realize. But you know, turns out how we deliver the medicine actually matters a lot, because we have this big gatekeeper, the gut, and our gut has Parkinson's, and it just doesn't allow for good, efficient absorption. And I always ask at patient support groups. Just yesterday, I was speaking to a patient support group, and without fail, how many of you have heard that levodopa stops working with time? And 50% of the people always raise their hand. And turns out if the brain can see levodopa, it knows exactly what to do with it every time. Whether you have Parkinson's 1 year or 100 years, doesn't matter. Your brain will always know what to do with levodopa, but it's got to be able to see it. So the under the skin infusions of dopamine are pretty strategic because it allows us to deliver the dopamine bypassing the gut, and that way it can go to the brain and do what it needs to do. But a lot of times what happens if you're on medicine 4, 5, 6, 7 times a day, which that's almost impossible to avoid protein, for example, when you're on something that often, it allows us to titrate the dopamine to 1.37 milligrams. So if someone is dyskinetic and they're wiggling, we can reduce that dose ever so slightly. Or if they're off, we can increase it ever so slightly without these big roller coasters one way or the other. So that's been very helpful, and we were thankful to be a part of the clinical trial. And so we have experience in that already, and it was nice to see our hard work as well as everyone around the world's hard work come to fruition. And our colleagues in Europe and Japan have been using the product already, and we're hearing good things from them. And so we're excited that we're able to bring this to folks here in the States.
So is that the Produdopa or no?
So that's a little different,
That's
actually.
different.
Yeah.
Okay,
So this is called foscarbidopa levodopa. So it's called Vyalev,
Okay.
and that's made by AbbVie, and that's what it is here in the States.
When did that come out?
And that was FDA approved last week. So
Okay,
brand new.
Brand new.
Yeah, brand new.
Oh,
And so we're excited about that. The second medicine that was FDA approved recently, probably like a month ago or something like that, is called Crexont. And that's a different version of, if you've heard of Rytari before, yet another version of carbidopa levodopa, very strategic and important, but it has immediate release and controlled release carbidopa levodopa in the same capsule. And why that's important is not only do you get a peak initially when you first take the medicine of your levodopa, but it stays up and kind of lasts. And so what I say to patients is from point A to point B is much smoother. You still need the medicine 3, 4, 5 times a day, but your point A to point B is much smoother without these big roller coasters. And so what makes that different from Rytari, for example, is that it has a special chemical part of the new medicine that makes it more sticky in the small intestine. And the small intestine is where our medicine gets absorbed, which is why patients with Parkinson's that have constipation, if you ever wonder, man, why isn't my medicine getting absorbed? I'm not feeling it kick in, but yet I haven't had a bowel movement in 5 days. Well, that's why, is because it depends on your gut, right? So it has some special properties to the medicine that helps it get more efficient absorption. So we're excited about that because we've waited for quite some time for that as well.
Yeah.
So again, 2 new medicines in the last
amazing.
month.
Yeah,
so.
yeah, that's so unusual.
Yes.
Yeah. Well, it's great that there's some progress.
Yeah.
Especially, they're saying now that Parkinson's is the most common neurodegenerative disease now being diagnosed.
Yeah, and they're estimating too that it'll increase even further as the years go. So we need to be prepared for that, and it's nice to have these options because, as you know, every patient's completely different. We have to find something that works for them.
Yeah. So I guess regarding the sub-Q new medication, you actually had experience directly working with it and testing it with your patients, and you feel. And they were happy with it, and how is the delivery? Like, where do they?
Yeah, great question. So, as with every medicine, there are drawbacks to any medicine, and there are benefits to any medicine. We have to kind of weigh those out. So, if you're familiar with the concept of an insulin pump for diabetics, it's a very small tube that kind of goes over the skin like a Band-Aid, and it delivers insulin into the skin. Well, this is the exact same tubing that delivers that, or similar tubing that delivers levodopa underneath the skin. And the pump itself is not implanted in your body, not like a deep brain stimulator, but it's something that you carry on your hip or however patients choose. Our patients get very creative with how they choose to carry these pumps, by the way, especially in Texas.
Pumps?
They're about this big. They're like if you have two iPhones stacked on top of each other or so, that's kind of how big the pump is, so to speak. And the important thing about that infusion is that it's a 24-hour-a-day infusion. And the reason why that's very handy for Parkinson's patients is because a lot of times Parkinson's patients will wake up at 3 a.m., 4 a.m., they can't get back to sleep. And you may think that's just insomnia or I can't sleep, but a lot of times dopamine is falling, and that's what prompts you to wake up. And yeah, you may go use the restroom, but then once you get back in bed, you can't go back to sleep. And so a lot of times that's dopamine that's helping you not be able to go back to sleep. Dopamine loss, I should say. So this kind of keeps your dopamine level up even at night. And then a lot of our patients will complain of what's called early morning off time, which means they wake up in the morning, they haven't taken their medicine yet, or maybe they do take their medicine and it just doesn't kick in quickly enough. And so they can't get started on the right foot, literally. And so this can help with that as well. So in the trials, it was shown to reduce off time by almost 2 hours and improve on time by 2 hours. And that's not to placebo. That's to optimized oral carbidopa levodopa. So as good as we can get you with your oral carbidopa levodopa, is able to optimize it even better by almost 2 hours. And so again, just emphasizing the point that how we deliver it makes a difference. But I think one of the drawbacks of any medicine that's delivered underneath the skin, though, is not in everyone. The skin is not always forgiving when you deliver something underneath the skin. Right. So when it comes to delivering certain medicines, it can make the skin red or irritated, and we just have to monitor that and make sure that the patients are putting on the cannula or the Band-Aid correctly, as you would with any under the skin delivery. So there, again, pluses and minuses, but we've seen some very good benefit to it. So I think it's an important medicine for a lot of our patients.
And is that something that you would use kind of late as the disease has kind of progressed, when people are not responding to the normal levodopa?
Certainly those, yeah, it's a great question. Certainly those patients it would apply, and we still consider all therapies for those folks, like deep brain stimulation and really anything. But everyone's kind of different in when they would consider it, but my rule of thumb is if you're on medicines at least 4 or 5 times a day, and you're having those roller coasters, we call them motor fluctuations, the ups, the downs, or troublesome dyskinesia, that's the time we would start thinking about this product, for example. But one thing to note there is before, with other continuous products like Duopa, for example, which you alluded to, that involved a procedure, and it's a temporary procedure and it's a minor procedure, but still it involved a procedure to have that place. Well, this doesn't. This can just be administered in the skin around your belly button or on your arm or on your thigh or on your flank. So I think that's appealing to some folks that want to still be very active, but yet they don't want to be tethered, so to speak. And this tube is very thin, very unobtrusive. So it's
promising.
maybe it can be used a little earlier than we would consider some things, but by all means, we want to do the most cost-effective and the most efficient way first. We want to use those treatments first. So if we can easily handle something with one pill 3 times a day, obviously we would go that route.
Yeah.
But for those patients that are having more motor fluctuations, we'd probably want to consider something a little different. And then that's when all of our options open up.
Right.
Yep.
So with these new medications coming out, I know new medications always come with a big price tag.
Mm-hmm.
How do you manage that?
Yeah, so so this is something I'm pretty passionate about, and I get fired up. So I love advocating for patients and peers, by the way, too. That's part of my role in the Texas Neurological Society, is serving as president, is to do just that, is to advocate on behalf of neurologists in the state of Texas and by proxy our patients too. And so we're quite resourceful when it comes to brand name medicine. So there are all kinds of third-party funding for folks that have Medicare, because copay assistance cards can't be used for that. Mm-hmm. So we're quite resourceful there in navigating that system. And I think that's another benefit, back to your first question, of a movement disorder specialist, is it's a daunting system for all physicians, regardless of specialty. And step therapy, you have to try this medicine before this one, or this medicine is not on the formulary, but this one is. And being able to talk shop with the insurance companies and write letters of medical necessity, that in and of itself is an art, and our staff is used to dealing with those things too. So any brand name medicine certainly has a high price tag, but there are ways to still get it, and we're resourceful there. The other thing is there's some new legislation that was passed, and so for 2025, and maybe the channel has heard about it, but with the Inflation Reduction Act, the donut hole for Medicare recipients is going away, but you have to opt into the program if you have traditional Medicare. Okay. So what that would mean is that your maximum out-of-pocket cost would be $2,000 per year, which sounds like a lot, but our colleagues in rheumatology, where they're getting $10,000 a month infusions, that's a huge thing. And then that $2,000 can be spread over 12 months, whatever that math is, but you have to opt into that program. So helping our patients understand the difference between traditional Medicare replacement plans, what are commercial plans, what are copay assistance cards, what are prior authorizations, what are referrals, all these things. We really have to do a lot of education with our patients, and then groups, like yours as well, I'm sure, talk a lot about those logistics, because they matter, especially when you're on a fixed and limited income for our seniors. So.
Yeah, it's a lot to juggle.
It is. It is. So having someone that kind of help navigate that, I think, is great. And again, leveraging all resources.
Yeah.
So.
Yeah. Well, you need a whole team.
Amen. Yes.
Sure. Yeah. Okay, that's great. So what about some of the medications, like the rescue medications, and how these newer drugs? How do they kind of fit in to the whole regimen? Yeah,
rescue medicines are still very applicable, I think. And what do we mean by that? So, the way I explain this to my patients is my whole job as movement disorder specialist is to keep your gas tank full of dopamine. That's kind of my analogy. And the problem with Parkinson's is that you have a hole in your gas tank that's getting bigger and bigger. So my whole job is to keep the gas tank full, right? That's our goal. Now, because of the inefficient absorption, some of our patients have a lot of difficulty. They'll say, well, most of the time I'm okay, but man, when I'm not, I'm not. So it's hard for me to play pickleball or box or, play a round of golf or go to church or go to a t-ball game for grandkids, whatever the case may be. If they are off, they are off, and that means their med's not working. That's where the rescue medicines come into play. So, and we have a variety of different medicines that we can use for that. For example, one medicine is called Apokin, which is a little clicker pen that helps us to be able to get someone from the off to the on state within 15 to 20 minutes. So that's a pretty powerful thing. And it's titratable, so one dose doesn't fit all. So patients can figure out, or we can help patients figure out what their dose is that helps them to get back into the on state. So that's one rescue medicine. There's even an inhaled version of Levodopa. Again, one of the many versions of Levodopa that kicks in quickly. So again, it doesn't replace the background recipe, so to speak, but it certainly can help between an on and an off. And I'll also add that some of these continuous options that we've talked about already, even some that have, like Duopa and that have already been on the market for a while now, 8 years or so, they also have an extra dose button. So it also serves as kind of a rescue if you need it. Same thing with the new version. And then there are even 2 other versions of pumps that are before the FDA right now being looked at and evaluated. So hopefully those will go through as well. One from Supernus, apomorphine infusion, that's been in Europe for 30 years, but yet hasn't made its way here to the States. And then also another one from another company called Neuroderm that's another subcutaneous levodopa product. So again, we've got good options that are coming out for Parkinson's. We just need them to come through.
Yeah, that's, I think it's a really unique time in the Parkinson's world. I mean, it's great to see all these changes.
Yes, yeah.
It looks like, I think Zoe, it looks like we might have a few questions.
Sure.
But let's see, we have a few people on with Joe and Maria, Allie, Brad, Sarah, Kim, hi.
Hi, everyone.
Heidi. And we have a question. Let's see, Maria said she is experiencing muscle stiffness, and how can she manage the pain? Do you have any?
Yeah, so that's a great question. Thank you for that, Maria. A lot of patients will hear for some reason or where, I'm not sure, but that there's no pain in Parkinson's, and that's simply not true. When dopamine specifically is starting to wear off, you absolutely can have pain. So now knowing what's Parkinson's and what's back and what's this or that, that's kind of tricky. We've got some things we can do to tease that out, but usually when dopamine's wearing off, that's when you can have pain. We call that dystonia. Sometimes the tightness or the curling that a person experiences with Parkinson's can be quite painful. So I always tell patients, look at your watch. See what time you're having those symptoms. Oh, Dr. Soileau, I have those symptoms all day long. But if you actually time it and you look and you write that down, you'll find that there usually is a pattern to that. So if we know that you take your medicine at 8, noon, and 4 p.m., and you notice that every evening around 3:30 or something after lunch, you start to have symptoms of pain, then we know that maybe your dopamine's wearing off. And so we can either increase the dose of your medicine, increase the frequency, give it, squeeze your times together a little bit more. We can give you a rescue therapy like we just talked about. We can add on other medicines that we didn't even talk about today that can help prevent the breakdown of dopamine. So truly, there are a lot of options depending on what type of off time you're having. So some patients feel freezing, some patients feel like their medicine doesn't kick in fully, some patients feel wearing off, or sometimes you take a medicine and it just doesn't even work until maybe the second dose. And each one of those things are different. We have different approaches to help them. So the bottom line is there's plenty of options to help you with pain and Parkinson's. We just have to figure out when and why you're having it and then treat it.
Well, that is good advice. So I hope, Maria, you can
Take that back.
Take
Yes.
that back. Talk to your
Yeah.
neurologist.
Yes.
So another question that Kim has is she wants to know if you are already prescribing Crexont.
Hi, Kim. Thank you for your question. Yes, we are actually. We're already prescribing that. That's been out now for, I think, probably a month or so. And so again, we were waiting and kind of chomping at the bit, so to speak, to prescribe that because again, we had some good success with that and colleagues around the country with great success for that. And so as soon as we had the opportunity, we prescribed that. And again, that's a different version of carbidopa, levodopa, long-acting and short-acting mixed together. And it allows us to time your medicine 3 or 4 times a day. And again, your point-to-point's a lot smoother there. And so we've been prescribing that already. And we're lucky here at my practice, we can have samples. And so we're able to try samples and patients are able to try that before we have to write a prescription for that too, which also helps when we have to go back to insurance and say, actually, you know, the patient was having these issues and now we have so much improved symptoms here because they're on samples, they're stable, they're doing great, and now we have some ammo behind when we need to prescribe those meds. So it's a good question.
How soon do you see the effect?
Well, I think the key with any switch from one version to another is that we didn't get to your original version overnight. If you remember when you first started dopamine period, it took a little bit of time to get up to the magic dose for you, the perfect dose for you. So that takes us anywhere from 1 to 2 weeks to kind of find the right dose. I always say if we make a switch, we convert it over what we think you should be on, but if the patients aren't feeling as good as they were before at day 4, for example, or day 3, we need to know about it so that we can make that adjustment. So a lot of times when patients say, oh, Rytari didn't work for me, or even on Crexont, like I'm not sure it's working, it's almost always a dose problem, which means we have to be able to adjust the dose that's appropriate for you. Because again, there's no cookie cutter recipe that allows us to get it perfect. I wish there was. That would be too easy, right? So we have to make sure we're on the right dose of the medicine. And that's where you come in as the patient and your care partner, by the way. So remember, they'll see things that you don't feel at the same time. You'll feel things that they can't see. So both viewpoints are very important so that we know what medicine dose to put you on. So.
Yeah, I'm glad you're saying that about the care partner because I do think it is important that the patient and the care partner do often go to visits together.
Absolutely. Crucial, I would say. Yes.
Yeah, because I think that seems like it would be really important.
Yep.
Well, I see that we're getting a couple more questions, but I have a question for you.
Yes, ma'am.
While we're waiting. So, as the president of the Texas Neurological Society, and being a movement disorder specialist, I feel like it's like a little different role.
Yep.
And that, and how do you see your role in maybe raising awareness? So for Parkinsons, we have been really putting a big effort into educating people in our local community and global community, like what is Parkinson's? What are the early signs of Parkinson's? What, in more underserved communities, we want people to be aware of what it is. And maybe as a society, the Neurological Society, are there any plans or what are your...
Yeah, that's a great question. So I've been involved with Texas Neurological Society for many years, probably since I was in my movement disorder training, even as a young fellow, so many years now. And I would say the primary role that I have currently is really to advocate, again, as I said, on behalf of our neurologists and neurology providers in the state of Texas. So, and that has direct impact to our patients who are the true kind of recipients of that care, right? So I think advocating and making sure that our neurologists are aware of the changes that are occurring each and every year at the state level, at the national level. We have a variety of subcommittees, independent practice, academic, medical economics and practice, advocacy committees, communication committees, education committees. So all these different subcommittees that serve our members in the state of Texas. And by the way, we just celebrated our 50th year last year. So that's one of the oldest state organizations for neurology in our country, and if not the largest. So we're excited about that and happy about that. And we work closely with the American Academy of Neurology too for some of its efforts. And so as a movement disorder specialist, certainly I'm a touch biased in that I love the movement disorder population. And so we're always looking for ways to make sure that our patients are aware of what's going on and advocating for them. So I mentioned some of the changes that happen year after year. From a advocacy standpoint, just being aware of those things and having a seat at the table for with our state legislators that are making laws for healthcare and that impact our patients. I mean, just this past week, we had mobile stroke units, which are ambulances that actually have CT scanners built in that help improve access to care for people in rural communities and big cities for that matter, so that we can get the treatments that stroke patients need faster. And so our state legislators and their staff got to actually walk through a mobile stroke unit and see what that's like and understand where we're needing state funds and help to raise awareness on strokes and all kinds of things. And so similarly for Parkinson's, we'd like to see those advocacy efforts increase. And so one way that we do that is patients may not know this, but every year we have 2 huge meetings in the state of Texas where we invite vendors from all over. We have nonprofit organizations come, and they're able to just talk to neurologists. I mean, we have about 350 to 400 neurologists that pass by their table at this conference, and it's great to get the word out because, again, it's a small world out there, especially in a big state like Texas. And when it comes to movement disorders, people are coming from all over the state. They're retiring here, for example, even in the country, they're coming to Texas, so they need to be aware of what's happening within our state. So these are all just things that we're doing at TNS each year. And then I know our local organizations too, regional organizations like our Parkinson's groups around our area and certainly other states too, are very much advocating for all of these things in Parkinson's, which Power for Parkinson's is one of those amazing organizations and we're grateful to have. So lots of advocacy work to be done and lots of education to be done. And one thing that I continue to be amazed with in our Parkinson's folks is their word of mouth. They are never scared to talk about their experience and pay it forward because they remember what it was like on this side of things, and now that they're going through it and you have someone that's newly diagnosed and you remember what that's like, and to be able to share your story with them and talk to them, I think that's a very important thing too, and these kind of organizations make that happen. So thank you to those of you out there who are willing to do that.
Yeah, that is so important, and that's one of the beauty, what the way we conduct our classes. We are very inclusive. We have people that might be newly diagnosed versus other people who have had Parkinson's for many years, and they all come together and support each other, and it's a really I think it really helps people.
It does.
Just manage the whole process. And I think we have, see how we're doing on time here. Okay, maybe we can take just a couple more questions.
Yeah, of course.
Yeah? Okay. Let's see. This is, Diane is asking this question. She says she has orthostatic hypotension. and her blood pressure drops when she stands, even though she takes medicine to raise it.
Yeah,
I know
yeah.
that's a tough, really tough problem to manage.
I've got
have
you. I've
any
got you.
thoughts on
Yes,
that?
I do. That's one of
Okay.
the most common symptoms that we hear about. And rarely do our patients ever say, I feel dizzy, right? That would be too easy. So a lot of times our patients will say, I feel, and I don't know, Diane, if you feel this way, but a lot of times our patients will say, hey, I feel like my legs are rubbery, or they're going to give way, or I feel foggy, or I feel sleepy, or fatigued, or just out of it. I mean, they use all kinds of words, our patients do. And then we ask them, well, have you ever taken your blood pressure at that moment? And a lot of them say, well, I've taken my blood pressure and it's fine. But remember, your blood vessels, just like your gut and just like a lot of other aspects of your body, it has Parkinson's too. And so when you stand up, your blood vessels don't squeeze together as quickly, and therefore your blood pressure drops. And that can make our patients feel pretty lousy, actually. Imagine that. If you're not getting good blood flow to your brain, you don't feel good. And it can cause all kinds of symptoms. So the step number one is diagnosing it, making sure that we know what it is and that that's the culprit. So if I'm laying down or sitting down and my blood pressure is normal, but then I stand up and it drops to 80 over 40, that's not normal and that's not good. And we can treat that. And you alluded to that, I think, in your question, that you're on blood pressure medicines to help boost your blood pressure. There are a variety of different ones out there, and a lot of times it's frustrating for patients. We'll find they'll go to the emergency room for low blood pressure, or maybe they pass out, and then they'll get taken off their blood pressure medicine that they were on for high blood pressure. But then they'll go back home and the same thing will happen again, and then vice versa. And you feel like you're just chasing your tail, but no one ever stops to think, I wonder if it's just Parkinson's that's causing this. And it does the opposite of what we want. When we lay down, our blood pressure should go down, but instead it goes up. And when we stand up, our blood pressure should go up, but instead it goes down. So we have to treat that. The other thing that flies under the radar quite a bit are other medicines that may lower your blood pressure. So if your Parkinson's medicines are too high, for example, and the dose isn't where it needs to be, that can actually lower your blood pressure. There are some meds that are more common than others at doing that. Another one for us guys, when we're on medicines that help shrink our prostates, like tamsulosin, that's one of the ones that can fly under the radar. So, patients will say, well, I've been on that medicine for a long time. But remember, your body's changing each year. And so as much as I regret that, and I feel it too. So that medicine sometimes has to be adjusted slightly as well. So there are lots of different things that can cause low blood pressure. But at the end of the day, we do have treatment for it. But it is a challenging non-motor symptom of Parkinson's that can be very frustrating. So again, just making sure that your provider is aware of that and what's going on, I think can be very helpful. And so a lot of times we'll give patients a log to actually track their blood pressure so that we can see if it's going up or down. So.
Okay. We have so many questions. Okay. Well, I just wanted
That's
to say
good.
something because I think the other part of Diane's question, she was saying, her pressure is low. How can she exercise? And
Sorry, I missed that
no,
part.
I didn't
Yeah.
say that. And I just wanted to say, like for us with Power for Parkinson's and in our exercise classes, we definitely have people that have orthostatic hypotension.
Definitely.
And just anecdotally, the way the way we handle that is we always want people to stay seated. Like if they're feeling lightheaded, there's any chance that they are unstable that particular day, or we know they do exercise. I mean, unless it's extreme.
Yes, exactly.
If it's an extreme day or they're really, really having a very difficult time, of course we don't want them to exercise.
Yes.
But
listen to your body, I would say.
Yeah, I would say that, depending on how you're feeling, sometimes the exercise can actually increase your pressure too.
That's right. And there are non-medication ways that we can things that we can do to help treat that too. So for example, we used to tell patients to wear thigh-high compression stockings. Well, if you've ever tried to put on those thigh-high compression stockings, they're a nightmare. You'll fall and hurt yourself just trying to put those on. Well, now they make them with zippers. And so it makes it a lot easier to get on. Or something else that we tell our patients, even easier than that, I think, is to wear what's called an abdominal brace. And so sometimes a back brace, for example, it increases your abdominal pressure, not like a girdle per se, but like a back brace, and you just Velcro it. And so if you're exercising, that can be another way to kind of boost your pressure temporarily to help you get good exercise. And you're right, exercise does often increase the pressure a little bit, but if you're already having that when you stand, best to stay seated in that moment so that you're feeling okay. But again, if that's happening all the time, you should talk to your doctor because you need exercise. It's true that if you don't use it, you lose it, right? And then what you do right now affects you and your Parkinson's 10 years from now. So it's crucial to be exercising, very important. It's the one thing we know that can actually slow down your disease. So again, we want to enable you to do that, but we want you to do it safely.
Yeah. And just, this is another anecdote because my dad had Parkinson's and severe orthostatic hypotension where his top number, his systolic, would go down to 40.
Yeah.
So, and he survived that for many years. But one of the things that we did for him is he would often, I think it's complicated a lot of times by dehydration.
Yes.
People don't drink enough, and
Yep.
especially if they have incontinence, that's also a problem. So
Yep.
it's a vicious cycle, but
Yep.
we give him just some salt water.
Yeah.
And remarkably, I mean, a lot of times it actually, it helped.
Yeah.
Yeah, so, you know, there's little things that you can
Yep.
do.
That's right.
But it can be a tricky thing to manage.
Yeah.
So let me see here. Okay, I'm going to give you this. Oh. Okay, well, we'll just take a couple more questions. Let's see. So Joe asked, what options of being on, let's see. What are some other options than carbidopa, levodopa that help with other symptoms but maybe not tremors? Is there something?
Other options besides carbidopa, levodopa that help with tremor. So I'll use a little interpretation there.
Or maybe it's here. Maybe it helps with the other symptoms, but doesn't help the tremors.
Well,
that's
what I thought maybe you were asking, and so that's why I was going to take a little bit of interpretation leeway there. But you know, Parkinson's disease always, by its definition, has stiffness and slowness. Not like we're getting older and, you know, cold day outside, I feel stiffer, but I, you know, go to do something, it gets smaller and smaller. I go to write, starts off big, gets smaller. My voice starts off loud, gets softer. Steps start off great, but then they get smaller and shuffly. All of that means that dopamine is reduced. The medicine we have almost always works well for stiffness and slowness, but tremor can be hit or miss. So sometimes patients will even start off with essential tremor, you know, in their 30s or 40s, where they shake when they go to do something, but when they're resting, they're still. And then somewhere along the lines, that'll change, and when they have a resting tremor, or when their tremor will change to a resting tremor, where when they are sitting, and relax, they have a tremor, and then they'll also have the tremor when they go to do something. Well, again, there's no one perfect recipe for everyone, so we will often use Parkinson's disease medications to treat their stiffness and their slowness, and hopefully their tremor, but if it's not, we'll then go to medicines that we use for essential tremor even to help treat their tremor. And then there's even some seizure medicines we use, like zonisamide, that has good data in tremor. We don't use it in this case for a seizure to reduce your risk of seizures, but we use it to help treat tremor, dopamine refractory tremor. And furthermore, there are a few medicines that we were involved with in some clinical trials that that are ongoing with some other trials, and hopefully will make them their way before the FDA one day, which can help dopamine-resistant tremor. So again, there are some good things coming in the pipeline, hopefully, to help address some of your concerns there. I think a big step, perhaps, but a very effective step, is in patients that are very bothered by their tremor, we can often consider deep brain stimulation. And we haven't talked about that a whole lot today, but that therapy is what made me initially want to be a movement disorder specialist way back when. So again, it's not new, it's been around for a long time. Lots of new things, new technology coming out very soon for that too. But DBS is a wonderful way to treat tremor, especially in Parkinson's. So again, there's no one perfect recipe, but if we see that tremor is getting in the way for patients, we will certainly be aggressive with them. But that's a big step to go from a medicine to brain procedure, and I realize that. So one of the ways that we found to be very helpful is, again, leveraging the fact that our patients are such, they have servant hearts, if you will, and they want to talk about their experience and pay it forward. One of the things we've done is to kind of have patients that have been there and done that with DBS that worked well for them. They've gone through that experience. We like our patients at least to talk to them. We give them the medical side, pros and cons, but they also get that side from the patients that have actually been there. And then only then can they make an informed decision about whether to proceed. So if you truly have a refractory tremor that's not getting better with any medicine that we try, then we can consider something like that as well.
Okay, yeah, I mean, of course, I know not everyone's a candidate.
That's right,
You have to weigh the pluses and minuses of DBS. But
yes,
yeah.
and tremor is a little different, because there are a few different bullseyes in the brain, targets in the brain, we call them, that we can use. One can treat tremor, stiffness, slowness with Parkinson's, but not everyone's a candidate for that bullseye or that target. But then there's another target that we use for essential tremor, and that target can actually treat Parkinson's tremor too. And that bullseye or target is a little more forgiving about who's a good candidate for that versus the other targets. So again, we're able to consider all these things as we have a patient before us and find the appropriate therapy or treatment for them, and then with you and your family, you can decide if that's right.
Well, this was all really great information. I think we have a lot of people asking questions. I think we might be here all day. I wish we could answer all the questions. But I was wondering, do you have any, are there any studies in the pipeline or any new therapies coming out that we haven't talked about, or that or diagnostic tools that you want to mention before we kind of wrap up?
Oh man, there's so many good things. Yeah, but I would say I get commonly asked about what therapies are out there, and myself and other colleagues of mine around the state certainly have clinical trials that are going with new therapies that are not yet FDA approved, but that they're really fun to be in those trials because we get to know our trial patients quite well, in addition to our regular patients too. But if that's something you think you may be interested in, find a movement disorder center who's doing a clinical trial if you think you may be interested in that. And that will rejuvenate you a lot of the times, and I think you'll leave feeling encouraged when you hear about all the different things that's actually out there to help you with your Parkinson's. Diagnostically, we often get asked, well, how can a doctor just watch me do this and do this and walk up and down the hall and say, you have Parkinson's? And, sometimes it truly, since 1817, we've been doing it that way. And it can be a quite effective way to make a diagnosis. But sometimes it's not clear. Sometimes it's confusing, or the water is a little muddy there. And we do have, a lot of patients aren't aware, but we now have a skin biopsy that we can do. And we helped take part in that clinical trial as well, that can take a little snippet, 3 little snippets of skin about the size of a pencil eraser, and take to a lab and look for the abnormal protein that builds up in Parkinson's disease, and we're able to do that. And there's some early data suggesting that how that protein is deposited can even help distinguish between Parkinson's disease, dementia with Lewy bodies, which is a cousin of Parkinson's disease, and multiple system atrophy, another cousin of Parkinson's. Remember, there's not only one version of Parkinson's disease, there are several. So that, I think, is an exciting tool that we have, because for years we've looked for what's called a biomarker. How do we find a way to diagnose Parkinson's sooner than later? And we now are seeing these emerge. They're coming out, and sometimes they involve spinal taps, but in this case we have one that just involves the skin, and so that's exciting. And one thing that I heard recently at a large conference was a professor from MIT and her team are working using AI technology to use a respiratory belt that helps monitor your your breathing patterns while you sleep. And with a 90% accuracy, they're able to diagnose Parkinson's disease completely independent of tremor, stiffness, slowness, which we've done for years. They don't even need that, just looking at the respiratory patterns. Again, early stuff, not even out yet, but just to think that there are tools like that that can help us diagnose Parkinson's earlier. Imagine the possibilities that opens up. And so I guess I would just leave our audience with really being encouraged. No one wants to have Parkinson's disease, but at the same time, we have so many different options to treat them. It doesn't mean it's rainbows and sunshines every day, and I understand that. But we really do have some good options, and there's even more to come. And I feel very encouraged by that, and I hope you will too. So I guess that's the parting words I would leave with all of you out there, is that there are a lot of people around the world that this is their life. They're devoting their life to this, and I hope that you get to benefit from that.
Well, that was great information. I hope everyone could hear us enough. It seems like people, we did have some great questions. I'm sorry we couldn't answer all of them. But thanks for joining us today, and thank you, Dr. Soileau,
Yes,
for
my pleasure. Yeah, thank you.
being here with us. And hopefully
Anytime.
we'll have you back again.
Yes, thanks again. Bye, everyone.
All right, bye-bye.